Hi, Maggie. Hi, Kristen.
Hi.
Hi. So, great. Lots of people joining. Hi, Maggie. Hi, Michael. Nice to see everybody. So we're right at 11 o'clock. And hi, everybody. I'm Robin Shapiro. I'm the board chair of the Washington State Health Advocacy Association, and you are joining us for another community conversation. We're delighted that you're here. I just want to remind everybody that we are recording this call that will be made available to the public. So if you do not want to be part of the video recording, please turn your video off and your audio off. I'd also like to remind you to use the chat function to ask questions, or you can raise your hand if you'd like to ask a live question. Just go ahead and use the chat function below. Before we get started, I just wanted to remind everybody that WASHA, the Washington State Health Advocacy Association, is a not-for-profit organization, and we're focused on helping people transform from patient to active participant and partner in your care. And we're just delighted that you're here today. And we have our board member and medical director at Swedish Health Services, Dale Reisner, who's a doctor and, again, medical director of OBGYN quality and safety. She will be doing both portions of our talk today. So she will start out like we always do, talking about COVID, what's new, what do we know, mostly what do we not know. She's going to be starting off with that, and then we'll head into the topic for today, which is navigating pregnancy during COVID-19. There's a lot to talk about today. We encourage questions, and with that, I would love to welcome Dale Reisner.
So good morning, everybody, and great to be here on behalf of WASHA. These community conversations have been really awesome, and the feedback's been nice. So we really want to keep speaking to what you want to hear, and hopefully a little bit about pregnancy. I'm going to spend a bit of time, maybe a few more minutes today, about where we're at. You may know that we have a number of organizations across the country that are looking at projected models. We also, if you're interested, King County, you can get on the Public Health King County website. If you really want to keep track of things on a regular basis, that's the best source for the King County area. There have been some concerning changes since even last week when I spoke about where we were at with the progress of number of new cases and number of deaths. So as of yesterday in King County, there were 7,046 positive cases. Now we do know that screening is increasing, so we're expecting to see more cases picked up. Some of the asymptomatic or mildly symptomatic folks. There were 498 deaths from King County. So it was in the past couple of months that King County was really more than anywhere in the state responsible for the deaths. But now we're just about 50%. So we're seeing cases spread across the country, and some of them are rural counties. There have been clusters. And there's definitely racial and ethnic disparities. And this is something that's near and dear to my heart that we don't do well with. Washington State isn't as bad as some when it comes to the disparity between Caucasian and African American or the Black population. But we still have a disparity. And we actually have one of the highest disparities with outcomes in pregnancy and maternal mortality with the Native American Alaska Native population in the state of Washington. We're worse than some other areas.
Oh, I didn't know that.
Yeah, and that is holding, it's not quite as much of a disparity as in maternal mortality, but looking at deaths from COVID-19, we're seeing the same difference. So there are clusters now around SeaTac and South Seattle, which are very, SeaTac area is one of the most racially disparate areas in the whole country. We have a lot of immigrant population there. We have a lot of essential workers that are not making a lot of money. And we know that those folks are getting hit harder because they don't always have the ability to stay home. They have to go to work, and they don't have any kind of vacation or sick leave or anything else to fall back on. So what we're seeing is the rate of death per 100,000 is 2 times higher in the Hispanic and Pacific Islander population in King County than for whites. And the ratio of positive and hospitalized people, so sicker illness, is much higher in the Hispanic, Pacific Islander, and Black population.
And Dale, we also do have a question of just a
Yeah.
clarification in the number of deaths, 428. Is this an increase since the number last week?
Yeah, 498. And I'm going to talk a little bit about that in just a minute
Okay.
when I apply it to the rest of Washington State. Yeah, but it's 498 as of yesterday. So we get a much more accurate tracking with the King County data than we do. It's a little bit longer for the whole state and longer certainly for the predictive models. So I'll put that into perspective a little bit when I talk about that in just a minute. But anyway, so that those populations are sicker and more often need to be hospitalized. So so yeah, we had what we thought was and it was still our highest number of deaths that I reported previously on was on May 5th, and that was, on April 6th, and that was 26 deaths in a day. That is in the state of Washington, not just King County. And on May 5th, we had another steep spike up to 23 deaths. So just a week ago, we had a spike. And you can go on the IMHE COVID website. So if you just put that IMHE COVID into your Google search and look at how that parallels as people have become more mobile. So our most stay-at-home time and the least amount of social mobility was seen right around the time of those spikes of death. And I think then after that, when rates fell, people started moving around a little bit more. And you can tell if you go to the grocery store that the traffic is worse. Now, part of that is opening a few more businesses, but that's not all of it. And so where we are in the state of Washington, and this makes me really, really sad. If you were on the call last week, I said we would get to around 800 or upper 800s or 900 by August 1. We're already over that. So we're already in the state of Washington at 896 deaths as of May the 7th, so last Friday. And so now our projected 0 deaths per day, instead of being towards the end of May, is not till the 2nd of July. So we've jumped 6-7 weeks ahead with expecting that we're going to have more deaths because we're seeing more cases.
It's just amazing to me that a week can make that big of a difference. And I think it's very important. I'm just so glad that you're kind of bringing us through this because real time, because I do feel like people are kind of calculating risks a little bit more in terms of getting out and seeing people even at a distance. So what do you say to that for all of us who are going crazy and the weather is nice and we want to, socially distant, have a coffee with a friend or something like that?
Yeah, most humans don't want to be in caves, right?
Yeah.
Most of us need our social fix, whether it's a lot or a little. And, you know, I spent Mother's Day with me and my dog yesterday, not even with my kids. And so, so that's hard. It's really hard that we are doing those things. We all, I would say, have felt like maybe we could move ahead a little bit more, and that's in part because of things starting to open. So our moving around more makes sense from the messages we've been getting. But all along, the public health officials have been saying, go slowly and go carefully. And I think the biggest message is go carefully. Keep your physical distance. Keep your mask. Wash your hands. Wear gloves. Do those things when you do go out. And I think we can keep this contained. But now we're looking at, by August, something like over 1,000 expected deaths. And who knows what's going to happen over the next couple of weeks, because what we're seeing is delayed, of course, right? So we get this false reassurance or false drama around what's happening today. But that reflects exposures that happened anywhere in the last couple of weeks, probably. Many people start getting signs of illness within, 3 to 7 days, but not everybody. And we're seeing that particularly with our asymptomatic positives who lived with a contact or had close exposure with a contact and are not turning positive right away. And so part of that may be our behavior. So when your loved one first gets diagnosed with COVID, you're probably staying more carefully distanced, and probably and that makes sense because they're probably shedding. Their shedding is more likely when they're acutely ill. But we don't know when there are some people who retain that positive status for a long time, if they are able to transmit the disease or not. And so likely that this disease is transmissible longer than most of the viruses we've encountered in the past.
So maybe longer than 2 weeks after
yes.
symptom, or a week after symptom free.
Right. So we're getting where we feel like for the pregnancy side of things, as we start talking about that we are using more a test-based approach rather than symptom-free approach, particularly for patients' partners that had a history of having COVID or a COVID-like illness, trying to make sure that they get tested before we come to the hospital and things like that. Yeah.
So maybe we should get into the pregnancy topic, which is, we know it's a huge topic.
For sure.
Yeah.
And I did have, I'm going to move through it, I think, fairly quickly, and I know there'll be questions, but I'm hoping that I've pulled out the key things that you're going to want to hear about. So I will go through those bit by bit, and then, if you feel like you need to stop me along the way, great, and if not, we can just go. Prenatal visits, I just wanted to let everybody know, should be still happening. If you are low risk, you don't get very many of them, and that's fine because you're low risk. If you're high risk, you would be seen more often. You should have access to fetal testing if you're high risk. And what we are really concerned about is we're hearing patients who are low risk, who have fears about the hospital, not getting the few visits that they should be having because they think everything's fine. But that also includes not getting an ultrasound, making sure that the baby's anatomy is normal and the growth is normal, at least one anatomy ultrasound, usually around 20 weeks. Not getting glucose screening. So if you have undiagnosed gestational diabetes, you can have a stillbirth from that. So there are a lot of things that we want to reassure folks about that still need to be happening. So we can do a lot now with our telemedicine and our phone calls and those kinds of things, but it's not quite the same thing as laying hands on the belly, making sure that it feels like the baby's the right size, all of those kinds of things.
Can I ask you 2 questions?
Mhm.
Just so, and I know you're speaking on behalf of where you work at Swedish, so important to kind of differentiate between what is generally done
Right.
and what is done specifically at your place. But for the majority of pregnant women, will the area that they get seen, I'm assuming, is separate from people that are generally being treated for COVID and that kind of
True.
thing.
True.
So,
Right.
yeah.
So, yes, you're right. A lot of my comments are from my experience through Swedish, but also I'm part of the Washington State Hospital Association Safe Deliveries Roadmap. So, pretty
Mhm.
much aware. Not, I can't tell you of one specific tiny town what they would have, but the range of things that are available. So, there are some folks that are still seeing patients in their offices because they have pretty low rates in the community. There are other places where it's harder to do that. If you are in any kind of a metro center, there should be a place for COVID positive or suspected COVID women to get the kinds of care that they should have. So because we've dropped off on all the routine visits, when you go in, it's not very busy, so your exposure is low. All of the clinics are using, no matter where you are using appropriate personal protective equipment. And then if you're masked, you should be protecting yourself as well. So you're right, it's different in smaller areas, but remember, this is scattered across the state now. It's not
Mhm.
in King County, and and we don't know if it will reach the smaller communities that have been. There are a few communities that haven't been touched by it. Um,
Can I ask you
yeah,
another question, which is last week we heard from Fred Applebaum that anyone who was getting seen for cancer was screened, and if they had a partner who was or helper, that everybody was getting screened, and then if you had possible symptoms, you were getting tested. Is that the same for OBGYN or?
very variable.
Okay.
So there are mostly the bigger centers that have access to quicker test results have started doing some actual testing of women who come in either in labor or prior to procedures. So only in the last 2 weeks did we have a fast enough test in the Swedish system, and only at First Hill is where we started.
Mhm.
It's the biggest number of our deliveries for sure, and that is where we are trying to cohort our COVID positive or suspected moms. So the other 3 campuses that do deliveries in the Swedish system, if they have someone who's known COVID positive, send them to First Hill for delivery. So those places then again are much less likely for someone to encounter that, especially since the OB units are really sort of separate
Mhm.
from the other parts of the hospital. Um, and so we have been testing the day or two before our planned scheduled C-sections and our scheduled inductions, but not everybody. And so everybody else gets screening, verbal screening. There's a temperature screen at the entrance, the main entrance for Swedish, um, First Hill, and for the other hospitals at their units, because they have unit-based
Mhm.
entry. And most of the hospitals across the state are at least doing screening. The problem is that I heard even last week from some of the rural places that it takes them at least a day for a turnaround. So if you come in with either a contact of someone, which automatically makes you someone who needs to be tested, you will be treated as if you might have it.
Mhm.
And we'll talk a little bit as I move along about what happens then, or what may happen then.
Great.
Yeah. So everybody's changed their visitors policy, so we do not have open-ended visitors anymore. That has been viewed in several different ways. It we have women who've had kids before who said they loved it, just having the time with their husband or their partner, and it was quiet and they could focus just on having the baby and being with the baby and bonding with the baby. And nobody's in the hospital for very long. So, you
Right.
know, if family's going to visit, they can visit at home, and it gives the couple a fresh start. Some people really don't like it. And I got to say that if you don't think about diversity, many of the communities, having extra family around is part of their culture. And so again, it's an additional challenge for those folks, and they will not be viewing it the same way as the, you know,
Mhm.
the people like me. All my kids were born far away from my family, so I had that nice experience of quietude. So there's that. Some places will only allow the spouse. Some places will allow spouse and a doula or another support person. Each hospital does that based on their COVID risk, their amount of PPE, and their degree of COVID in the community. So you really need to trust them that they're doing the safest thing possible for you and your baby. And by doing that, you have a really low risk of, you know, entering an area at all that has somebody with a COVID patient.
So if somebody who's pregnant wants to be tested throughout their pregnancy, is that even an option? Is that typically done? If you're high
If
risk, is that available?
if your partner is positive, typically yes, you can get tested then. Um, the need for testing is more important right at the time of delivery, because the rest of the time, if you have mild symptoms and you're COVID positive, it's not a big deal. And we'll talk about this in just a minute, the whole sort of variability of expression of this virus. What we really want to know is, you know, if you are, for instance, if you're asymptomatic and you're positive and you're planning an induction at 39 weeks because you're 35 years old and there's nothing else going on and your baby looks fine, you know, it would be probably prudent to hold off and not do that while you're, you know, while you're positive. And most of the time we can figure out a contact, sort of retrospectively in those women. In our screening of asymptomatic patients, we actually were surprised. We had two in the Swedish group out of 10 days of screening. I can't tell you, that's probably maybe 10 people a day, not more than that. Not, well, it wouldn't even be that. It'd probably be closer to 6 or 8 a day. And one of them had a positive partner and the other one had experienced some mild symptoms. So they were not symptomatic according to who we would normally automatically do a test on, but not totally asymptomatic either. University of Washington has tested, they've been doing universal testing. So they screen everybody, and we do too, by phone prior to coming in for testing. And then their scheduled cases, they test in advance like we are doing. And then they have enough in-house testing that is their testing, that kind of like what Fred Applebaum was talking about, that, that the Cancer Center has, because they're using that same testing. And so they have been doing testing on all asymptomatic women coming in. And they've done 500 tests. That's includes Northwest, I believe, and Valley. And they've had 0 positives in totally asymptomatic women. So they've had a few, I think, in the same sort of folks that I just mentioned for us. So it really depends on the community that you're screening and the prevalence of the disease and how much the pregnant woman has sequestered herself. So our recommendation is that, if possible, you homestay for the last month of pregnancy, so that you are not, you know, if you haven't been exposed before by then, you're really being careful and really isolate. we asked people to stay at home and not go anywhere once the test has been drawn or done, because it's a nasal swab, between that and when they come in for their procedure. And then most of the places are doing that, just total stay at home between then. So the Department of Health has put out some neat guidelines. I sent Robin a copy. I think I sent you two of the same thing.
And we actually already have it posted up on our website. So if folks are familiar with where we're keeping our community conversations on the washa.org website, that is actually already posted up there. So thank you for sending that.
Yeah, that is what I sent was the English version. It's out in Spanish. They're working on other languages as well. It's meant to be, it's really beautifully done, the graphics. It's meant to be something that will remind people what to do, even if English is not their first language. And so there's lots of figures in it, and it also addresses what to do when you go home if you're COVID positive, and I'll talk about that a little bit more in just a minute. So in the hospital, I've already mentioned some of this. If you're COVID positive, or if you are symptomatic, or if you've been exposed, you are called a PUI, which is a person under investigation. So that could be your significant other, or that could be you. Significant others who are positive are not allowed in any hospital I know of. And so even if the mom is positive and their partner's positive, because it's one more person that staff and providers can be exposed to. However, most of the time, you're given the option to bring in a friend or a family member that hasn't been living with you that is likely to be negative. We're not automatically testing those people. So we're going to rely on that you're trying to do the safe thing. We're hoping that that's the person that, that is the safest to be a support for you. And so in most places that I'm aware of, if they're allowing anybody in at all, they'll allow in a substitute person. Lots of ability to FaceTime during the labor, that kind of thing. I already mentioned that the testing is quite variable depending on where you are in the state. Most of the staff is masked for second stage of labor now, which wasn't our normal. We always have recommended masking when you deliver in the hospital for birth, just because there's a lot of stuff that can get spread around. So that's not so different. If you are COVID positive, people have the option to wear N95s, the masks that are better for smaller particles. But not everybody is, not all the providers are doing that. We do not mask the patient when she's in labor. If she wants to, she can, but that's a tough thing to ask somebody to do. The other thing that's really important is that right now, the CDC and American Academy of Pediatrics are still recommending separation of a baby from a COVID positive mother or a person under investigation. So this is tough. We have information for parents, that we have a letter for parents that talks about this ahead of time. It's also in the Department of Health information. The Department of Health information presents it pretty much probably more balanced than what ours does, because we have a recommendation wanting to be risk averse of recommending towards the separation, since those two organizations are recommending that. We support breast milk, so we will help the mom with that. And again, depending on where you are, most in our Swedish system, the pregnancy suspicious folks, the PUIs, are getting resolved before delivery. And so we've had less of that. Mostly it's the COVID positive moms. We also have kind of created a patient decision aid, which I'm happy to share. I've shared with the hospital association. that gives the
Would you
fact.
share that with us?
Yeah, it gives
Okay.
the fact
Oh,
we
yeah.
have them right now. We have a lot of anecdotal stuff and not a lot of cases. And so we present it the way it is. And we and we want to have a discussion with mothers who are known COVID positive ahead of time so that they can have a mindful decision of what they want to do. And we will support them with whatever choice they have. And I would say that should be the case everywhere. It may be more pressure to separate in some places than others, but we really have strongly across the OB community tried to say, this is really the parent's decision. They're going to go home and do something. And I just don't want to, on my turf, want to see a baby get infected. So there is no vertical transmission that's been detected. So vertical transmission would be if the baby is delivering vaginally through the birth canal, is the baby getting infected from the mother? Or is the baby getting infected in utero from the mother? And so we have pretty good data now from around the world that there's no virus in the amniotic fluid and the babies do not have COVID-19 at birth. There have been a few cases, and I mean really few considering the number of pregnant women across the world that have delivered, where there's been a stillbirth or a miscarriage, late miscarriage, where placental material has tested positive for COVID. And
so can you repeat that? So there is not good evidence.
Well, there's evidence that the placental tissue was positive for COVID and the mother was positive for COVID, but the baby was not.
Okay.
So what we don't know is, could there be some placental dysfunction that might be related to a stillbirth? And I don't want to overemphasize this, but there's a lot of talk in the OB community about this. A few case reports are getting published really quickly, and we don't have any clue what the background miscarriage rate is in that same setting. And there are stillbirths that happen, and there are second trimester miscarriages that happen, irrespective of whether you have COVID or not. So we don't have complete information, but what I want folks to really understand is that the risk is gotta be incredibly small. It is not like what we saw with Ebola and stillbirth. It's not like what we saw with Zika and babies being affected in utero. We have enough to see that. So the majority of pregnancies are gonna do fine.
So is there anything to do if
No,
a
no,
pregnant woman
yeah,
is positive? Will
right.
there be anything done differently?
Nothing will be done differently. If she gets really sick,
Mm-hmm.
she will have access to some of the experimental treatments. Now, I always say this wrong, Remdesivir.
Yeah.
Now been made available. Swedish has been participating in a study, actual trial for that for several months now, but it's now been made available from the FDA to any hospital that requests it. So a really sick mom could have access to that. But yeah, we're not going to expose people to drugs that may have a downside themselves, may not be that helpful, especially when you have mild disease. So we don't really understand at all yet, but I just wanted it to be clear that babies are not born. They don't have congenital coronavirus 19. So
Okay, that's really interesting. And we did have a question come in from Maggie Pheasant about, so let's say that the mom is positive, the baby is born and separated in the hospital. Does that mean that the baby can stay in the hospital separated until the mom is through her symptoms, through her course of this virus, or?
No, that's why
Mm.
a lot of people say, well, why separate the baby from me now when it's got to go home with me? There are a whole set of instructions and guidelines for people who want to continue that. And that has baby in a separate room, which, a lot of moms don't do now, but used to be
Right.
really common. You went home with a baby, the baby went in their nursery, right? So baby in a separate room and a caregiver who's not been sick, taking care, primary care, and then moms can decide whether they're going to actually breastfeed or they're going to continue to pump. So we really, really, really strongly encourage breast milk. Now, if a mother who has COVID never wanted to breastfeed, then so be it. But for those who do, there's a way to provide breast milk, which will have your antibodies, when you're making
Mm-hmm.
them. And so that
And breast milk again is not
named
found to.
virus. That's
Yeah.
exactly right. Right.
Yeah.
So it'll only have all the good stuff.
Yeah.
Yeah. So when I said there's no vertical transmission, there has been horizontal transmission. So the youngest baby we know of was 3 days old in the United Kingdom, diagnosed with COVID-19. Got sick, I think, survived and did okay. In the UK at that time, they were rooming everybody in with their baby. So we don't know exactly whether rooming in and of itself, or whether there were, somebody was more lax about handling that kind of thing.
Mm.
When moms decide they want to room in with their baby, even if they're known COVID positive, then we keep the baby 6 feet or more away from her in a bassinet in the room with her. There's usually a curtain or some kind of divider, stand screen that gets brought in, so that if there's coughing or whatever, that stays on the other side of the screen. Then the nurse, or if there happens to be a family member there, again, in the Swedish system, we don't have a family member there with a COVID positive mom, but so nurse who would be taking care of the mother and the baby anyway in the hospital would help the mother if she wants to breastfeed instead of pumping, clean off the breast, gloves, mask, all of that. So we're not trying to do skin to skin unless there's a, COVID negative dad at the time immediately after delivery who wants to snuggle their baby skin to skin. That's certainly fine. But with a known positive mom, we're trying to avoid that because we just don't know. And, you can't put Clorox on your breast. That's not so good for the skin. So we're cleaning, but, we're not boiling water, and we're not, we're cleaning as best we can.
So if somebody wanted to be cleaning and just making sure, what kind of cleaning can be done,
Yeah.
at home?
Yeah. So any kind of 60% gel, we can apply to the breast. We clean it up, let it dry, and then we'd wash that with normal sort of soap and water afterwards, just so that it's not the high degree of alcohol when the baby starts suckling. So that's typically how we do that. And the hand cleansing and gloves and so on. Yeah. We have not a lot of data, but we have decent data on children getting infected with COVID. And there's not as high a rate as there are for other adults or older young people even. But if you look at all of the children under age 18, the ones that had a higher rate of severity of disease are those under 1 year of age. So somebody who's got an infant at home and becomes COVID positive, the same sort of separation and cleanliness is really strongly recommended because some of these kids get quite sick.
And you're saying also that the mother is wearing mask and gloves. Is that correct?
So if the baby's brought to the mother to breastfeed, she's wearing a mask and ideally gloves, or certainly, very good hand washing. Yeah. Yeah. The, See, there was something else I was going to mention. I think I kind of lost it.
Sorry, I interrupted you. We're
They
going to get to some of these questions too. So,
say that, typically pregnant women are considered to be immune suppressed, and that's a survival thing, right? When you think about it, the baby is half of somebody else, and so why would we ever not miscarry every pregnancy? But because it's foreign tissue, we have to take steroids and all kinds of immunosuppressants if we have a graft of some sort from somebody else. And so part of our ability to carry a kid to term and have a beautiful, healthy baby is suppressing our immune response so that we don't overdo it. And so typically when there are bad viruses around, pregnant women are very susceptible, more so than the general population. So you'll see pregnant women, young children, really young children, and elderly. This virus does not seem to be attacking pregnant women any more than other people their same age. So that's reassuring. And the percentage of folks that are getting intubated and getting sick, and I don't even know if we have a maternal mortality from COVID. I would have to look to New York, where it seems to have hit even, so hard, but not in Washington State. So,
interesting.
So that's really good, because typically the lungs are sensitive for pregnant moms. We have had mothers who got delivered early with bad pneumonia and have had to be intubated and in the ICU, but they're few and far between compared to what we would typically be worried about with influenza. So that part should be a little bit reassuring to pregnant women. It doesn't mean you want to not protect yourself anyway from exposure. And so there are some complications we're seeing. They're not different from, well, there's only one that's different from everybody else. And the ones that are different from everybody else are anything that has to do with the placenta. So placentas play a big role. We don't understand it fully, but they play a big role with whether you get preeclampsia or not. So that's that pregnancy-induced hypertension that is severe. And so there appears that there may be a slightly higher risk for preeclampsia typically it looks like it's in the women who are quite sick when they come in. So they're the ones that were really symptomatic. And then I already mentioned that, not sure about the miscarriage. There may be a higher preterm birth rate. That is not uncommon when mothers get sick with anything. If you get a kidney infection, you have actually quite a high preterm birth rate. So there are, that would make sense if it is.
And we did have a couple questions here related to this about, what's being done for women with gestational diabetes, knowing that this is from Michael Wood, knowing that diabetes makes one at much greater risk if infected of having severe disease and death. And same question about obese pregnant women. So those
the
factors.
The diabetes is a high-risk pregnancy, and so those women should be getting the same care and testing that they normally would for fetal well-being. And if their glucoses are in good control, they should do well. The susceptibility for infection tends to be more bacterial than viral with diabetics, and maybe it has to do with bacteria wanting to eat sweet things. Yeah. And so the more out of control the sugars, not only your immune response might be different, but circulating high glucose may provide a nicer environment for some of those bacteria. So I've not seen, there are just not enough numbers reported to say whether diabetics are getting sicker than anybody else. We have not seen it anecdotally. And actually seen it in any written reports either.
And is there any evidence or feedback on obese women who are pregnant? Okay.
Mm-mm. Just the same. It's a higher risk, the higher the BMI,
Yeah.
and so they should be getting the care. What's a concern is we've heard, this comes not from Washington State, but we've heard women who, well, I shouldn't say that because there may be some of this going on the east side of the state as well, but um, there are women who are concerned about coming to the hospital, afraid they're going to get COVID-19 in the hospital, which I think, as I said on the last call, you're safer in the hospital these days than you are in the grocery store. Because in the grocery store, I can tell you, because I have to shop for myself here, there are a lot of people not wearing masks, and there are a lot of people not being that careful, and that, their bare hands are handling things, and you will not find that with the people that are taking care of you in the hospital. So
Yeah.
yeah. So the concern is women who at the last minute decide they're going to deliver at home, and we have had some really bad outcomes with that. So I don't know if often we don't get full information from the person when the baby comes in as to whether there was an appropriately trained attendant there or not. But even if there was at the last minute, that's not good. And I do know of a diabetic in the state of Washington somewhere who has not been coming in for routine testing because of fear, like the calling in sugars and all that kind of stuff, but physically not coming in. So we really need to encourage people, if they're higher risk, to do the care that they need to do, for all the reasons I've just mentioned. It's more dangerous, as Fred said last week. Your cancer is more dangerous to you, and your underlying causes are more of a problem than COVID would be necessarily for you and your delivery. So
yeah. So to that end, because we have about 15 minutes left.
yeah.
The time's whizzed by, as it always does. But for women who are pregnant and their partners, and they're planning for their delivery, and we always like to say, pack the to-go bag and have your plans in order and all that kind of stuff. So now that we're in the COVID era, is there anything that you would recommend that they do differently? Is there anything to do or plan or prepare for that's different than normal?
I think the safest thing, if they can do it, is to really isolate at home for the last month of pregnancy. And that way they don't end up getting COVID and having to deal with these types of decisions and concerns for their baby. To do what it takes to wrap their head around that it's a different birth process than what they thought it was going to be at the beginning of the pregnancy. And this is big because we had a community discussion about grief and loss. And this is a loss for some women more so than others. And I think that once people get through the experience, they realize it's not as bad of a loss as they thought it was going to be. But going into the delivery, not being able to do it exactly the way, we become very consumerized about how our labors go and how our birth is supposed to be in our eyes. And so I think preparing ahead of time that, what if something goes on that, all of a sudden you're COVID positive at the end, and how would you handle that? Or more importantly, be happy that your partner can come in with you and enjoy this birth, and, take pictures and do all the things that you would normally do. Make it as normal as possible, I guess.
And anything after delivery that families need to be prepared for during this time too?
Yeah. Well, I'm concerned, as we've seen people widen their social networks in the last few weeks and the disease rates going up, that I would be careful about having folks come into your house. and how you will do those expanded family visits. And maybe a lot of that, some of it, if there are people that live at a distance, can't come anyway because of the travel restrictions. But I'd just be cautious about that. Do as much as you can with FaceTime, and with these, you can do free Zoom family gatherings for small, 10 people or less or something like that. So take advantage of those things. Actually, that's not a bad approach. If you're trying to keep your baby the safest from illness, is to keep you and the baby in the house for the first 3 weeks while the breast milk is coming in full force and your antibody production is getting through to the baby for whatever you've been exposed to in your real life. So I would say think carefully about when you bring people in. Now, as the weather's getting a little bit better, maybe you can visit, on your porch or something like that. But still be careful. And maybe grandma comes in and wears a mask and gloves and still says hi to the baby that way,
Mm-hmm. Interesting. So I have a question here. So someone who is 4 months pregnant, due in October, company is flexible and allows her to work from home even when people start going back to the office. Would it be recommended that I just continue to work from home until baby comes? Or should I just make sure to isolate that 1 month before? I'm trying to decide if I go back to the office or not this summer. Thank you for the question.
I'd stay at home if you have the opportunity. Yeah.
Mm-hmm.
Yeah. Because, unless your office, most offices, even if there's separate offices, don't allow you to do that physical distancing. You pass people in the hall and all that kind of stuff. And if your company is one that allows you to do that and it's not a deficit, I'd stay at home. You can go outside and take a 15-minute walk in the middle of the day and get some fresh air and those kinds of things. I think that would be lovely.
Mm-hmm. Great. Thank you for that question. And I want to make sure that before we wrap up, if anybody else has any burning questions to ask Dale while we have her on this subject, would be great to send them to me now. And this has been so interesting to think about. I know that we've had a lot of people contacting Washa asking questions about pregnancy and certainly delivery and just making sure that people have the information that they need and are not too fearful to actually get checked on. I am curious if we if there's one central area that's kind of collecting data on pregnancy and COVID, or how is that being tracked?
Yeah, that's a great question. And yes, and it's in California. So
Okay.
in our, I can find the access. In our system, one of my maternal fetal medicine partners had kind of made that connection and is forwarding cases, but you can self-report, or a provider can self-report. We really want to do this registry and have as many people as possible. So this is for known COVID positive. And that way we can look at, see at what point in pregnancy are you COVID positive? How did it go? It's all done with the pregnant person's approval and they're the one that gives the information. Basically, they have to authorize the information. So if you're if the person you're working with doesn't want to do that, it's not that helpful. There's a registry in California that trying to collect cases from all around.
Great. Also have another question. Anything specific to be done with baby and siblings at home? And this is a question that came from a woman who has four kids.
And they just want to just kiss that baby, don't they?
Yeah.
Well, I guess it depends on how isolated the kids are. I know that it's been super hard for kids. and just the ability to get out and run and play and do stuff like that. And a fair number of kids have had cohorts that they're hanging out with, so they're not necessarily staying in their own home. If your children have been in your own home and haven't had contact with other kids, then and none of you are COVID positive, then it's probably fine for them to be doing what they want to do with a baby, not dropping it, but but if they're like many kids and they're playing, they're up riding bikes now that the weather's better, in a neighborhood bike around or that kind of thing, then kids are not, they haven't been noted to be as infectious to others as they with COVID-19 as we've seen with some other, like the common cold is so easy for them to pass along. It's also coronavirus. But it may be because fewer of them are positive, and we have this data from Australia where they kept school intact and they tested kids at various points in school. So very small percentage of kids that were positive in that setting, even in classrooms in elementary schools. I think it's tough with the kids, with the siblings, because if they have had the need to be around their buddies, then maybe the risk is a little greater.
So this is from Penny Blaisdell. Sorry if I mispronounced her name, Penny. She says that the New York State has a COVID-19 maternity task force that has made recommendations that have been accepted by the governor. So I don't know their task. I'm just thinking, ask the question about who's collecting data. So it sounds like
Right.
maybe they're an organization.
Yeah.
Each
state has taken some things on individually, and certainly as we get more information and the dust settles a little bit with this, there will be collaboration across the country with different, probably the maternal fetal medicine groups who will want to try to collect everything from across the country and really dissect it and see what we can figure out, because we are concerned that we will have another big swarm separate from the stuff I talked about earlier, but by fall. And we'll have flu season at the same time. So it's going to be super concerning. But in part, I would say to the woman who's not due till October, stay home, because yeah, you can still get a flu vaccine. I would encourage that for sure. But we just need to gather everything up. We don't know if the virus that we had on the West Coast is exactly the same as the one they had in New York. In fact, we think that it's different. And we don't know if that created more severity in their cases or if it was something else that happened. Certainly their transmission rate was bad because they're so tightly wound in that city. And very few people have private transportation, so they're using public transportation or cabs or that. So pretty easy to transmit in that setting. And a lot of people eat out. I mean, it's just a very different way of life.
Although it's disappointing to hear, and I think we have to keep in mind that, our transmission rate and cases are up. And so that's a very sobering message, I think, for everybody who's listening, and for all of us who are talking with our clients and our family members, friends and neighbors, that we really do just need to continue to be vigilant and make sure that if healthcare is needed, that the hospitals are, sounds like, safer than many other places. So I want to just thank Dale Reisner. Thank you so much for joining us weekly and for what you're doing on the front lines, and to all your colleagues. We're we're just at time. And if you have enjoyed this call, please join us again next week, same time, same place. We will be talking about ventilators and end of life plans with Dr. Jim Demain, who's retired pulmonary doctor and professor emeritus at the UW, and Bonnie Bazell, who's program manager for Honoring Choices Pacific Northwest. And you will also be receiving a survey today. And like always, we really appreciate that you give us that feedback and let us know what other topics and speakers you'd like to hear about. So thank you so much. We'll see you next week. Thanks, Dale.
Sure.
And thanks for everybody who was on today. It was really, really a great conversation. Thank you.
Bye.
Bye.